Welcome. Just a little intro before we get started. This is a huge deviation from what we normally do. Normally, we're talking about addiction medicine, education kind of stuff, and this is kind of a little bit like that, but we're going to pull a story out of the news, which is, I don't know if anyone's been following or not, but it's the Alex Murdaugh murder trial. This gentleman who's quite an established, well-respected man in his legal community, Alex Murdaugh, is on trial for allegedly murdering his wife, Maggie, and their son, Paul. So why are we talking about this at all? We're not a crime show, but this gentleman open about his opiate addiction. And the question we're looking at is, can somebody do $50,000 a week in opiates, which is what he alleges. It's both what the prosecution is looking at and the defense using it as in different ways. So we thought we'd just have a look at that question and figure out if that's something that's possible or not. Thanks for joining us, and hope you enjoy. I know I threw this story at you in the morning, but there's a story in the news about this gentleman in South Carolina who has allegedly murdered his wife and his son. His name is Alex Murdaugh. And why am I bringing this up in an addiction podcast? Might be the next question.
Well, JP, I mean, why are you bringing this up in an addiction podcast?
Well, that's a great question, Whip. I don't know where you came up with such riveting questions. So his defense has brought up the story that this gentleman has an opiate addiction.
Yep. And
he's spending upwards of $50,000 a week on opiates.
Yep.
And this was in People magazine yesterday. So.
Yep.
And a lot of people saying, oh, $50,000 a week, that's impossible. So I thought, hey, that's kind of in our wheelhouse. Is it just to even look at that question? Is that possible?
I mean, I think it's a great question. I think there's so much to unpack there, right? And part of it is my own personal thing. I can't think of something more horrible to do than to murder your wife and your child.
Allegedly.
So fair enough. So, but there have been cases we've seen in the news where men have done this, right? Where men have murdered their wife, and sometimes it seems like it's out of anger. There was that one person who drove a Tesla or something in California. And I just can't think of something more horrible. And that in itself just brings a different experience in my mind and body, right?
Ironically, I think the Tesla guy was a physician.
Yeah, Indian physician, right? And it was funny, because it's not funny, but you are like, hey, what's going on with you people or something, there's 4 or 5 headlines in the news where these Indian physicians have murdered their wives and their kids. And I'm just like, oh shit, well, at least it's a standard that I could definitely surpass, in terms of moral and ethics and so forth. But what horrible things that have happened in the news. And you don't know how much of it is just glorifying, or because that's what people read about, or is there a trend? I mean, I find it so viscerally uncomfortable. But I think we can pull back to that simple question, right? How much can people spend on an addiction? And one of the cases I remember so well was around, and it was interesting because I've known the person for a while now, and it was someone where they never heard of buprenorphine. And, they had a 10-year addiction. And when they got on buprenorphine, they're like, what the hell? They lost her. And this person was a business person, right? And so they see the housing prices go up. So they see all that stuff go up. And they're like, I lost my house. And every 10 years in Toronto, it's like, what, $500,000, $1 million for the person. So it was just, it's one of those things where when people are in that cycle, it's very hard to stop. And the other thing that I'm not so good at is that when people have unlimited means. So when people have unlimited funds to do whatever they want, it's a much harder sell. And some people get really good. They hide it from their wife, they hide it from their kids, they hide it from their parents, they hide it from their work, they hide it from all that stuff. It's not like you can smell it like alcohol.
Right.
And your body gets used to it, right? Your body absolutely gets used to it. And I've seen people where it's like 30, 40, 80s a day. And they might come to see me once just because somebody makes them come. But if there's no negative consequences and they can hide it, and all I'm saying is it's a very tough sell when someone's in the throes of substance use to try to convince them that a life without it is better.
Right. And I think...
And then maybe it's not my place to do that, but I'm pretty sure when he looks at his life now, he almost wishes he didn't have that 50,000 a week addiction.
Yeah, and I think, well, sure. I mean,
or maybe he does. Maybe
there's a
maybe
big...
he doesn't
Well,
regret it.
let me frame it another way. So he's a kind of a scion of the legal profession in South Carolina. His father's was one of the top judges. His grandfather, his great grandfather. This guy is an established.
So it wasn't poverty that led him to.
It's not poverty, but that's not the point. My point is that in order to get that buprenorphine that you're talking about, you got to come out of the closet. You got to go to an addiction doctor. You got to go to a physician.
Oh, I didn't even think about that.
Right. So you can't. It's not like he can get that illicitly. Although, funny enough, I have heard of. I've supported multiple patients that have bought and sold buprenorphine illicitly.
Yeah, no, absolutely. And in
Which
some
seems
areas
ridiculous because it's so accessible.
Well, no.
For us.
It's accessible for us, and because with OW, ODSP and stuff, it's so available here, right? I've seen buprenorphine diverted, right? A lot as well, and I regularly see patients that will borrow it from friends to cover their withdrawal symptoms, which is fair. I'd rather they take buprenorphine than I don't know, even naloxone, right? Because buprenorphine lasts longer.
Right. I remember a patient that brought in a jar of it that was really hard to look at because it was covered in saliva in the jar.
Yeah.
And he'd paid $20 each for these saliva-covered pills that he bought from somebody else. And I'm like, brother, we're going to hook you up here, right? You don't need to pay anything. You got a drug plan; it's covered 100%. Let's throw this jar away, right? And it literally, it was so sad to me, right, that somebody would go to that trouble, and he didn't have money to pay for that, but that's how much suffering in the shadows, as you've called it before, right, can do to somebody, that they would pay $20 a pill for these, and he's like, he had some concerns about taking them because he thought he was actually concerned about infections, or the guy apparently was a little, he didn't really want to share saliva with this gentleman,
of course,
but he bought all these pills.
What a great twist. You brought up this morning about bringing up this topic about this person who allegedly murdered two family members, and I just didn't know where it was going. And then I never thought of the shame of disclosure, and I think you're absolutely right. And some of the people where it's lingered for years, lingered for decades behind the scenes, a big part is the shame. Especially for people that are independent, competent, capable in all of these areas, and their entire public image is one of success, right? And it's any deficit is hard to show, and I don't know what it is about me where I tend to show my deficits first, in meetings and stuff. But we also struggle with the shame and stuff around people when they start to need a cane, they start to need a walker, they start to need a wheelchair, they have falls and all that stuff. We see when people where beauty is a big part of their identity, and they start to age and they don't look the same, and then they don't want to do the same things and so forth. And so shame and stigma and the judgment that people have on themselves, and we see it as healthcare providers, is much more than anyone I could think would have on them. Yeah.
Well, I mean, it's but it happens, right? And we know it does. Now, I'd like to talk a little bit about the concept of tolerance, and how someone could get up to this $50,000. I'm gonna give lead with a little bit of my lived experience, if that's okay, and I guess it's okay because I'm talking. I don't often talk about. I've had two kind of rounds of addiction in my life, and the first one was with something called ketamine.
Okay.
This is something we've never talked about.
No.
And this is an interesting drug which will tie into tolerance, because so ketamine is the type of drug that you can $30 of ketamine if you and I were to start taking it today would last us a pretty good weekend, right? And we'd be pretty messed up for the weekend. We'd all be happy, right? But if you were to take that ketamine every day for let's say 30 days.
30 days.
Yeah, you would be now at a habit which would be closer to $1,000 a day. And that's where I was at ultimately with ketamine, is I was doing $1,000 a day of ketamine, and nowhere near as high as I would have been on the first day.
Huh.
So
do you think you did a 2-week gap in between each dose, or?
Yeah, absolutely. No, you would have. Yeah, if you just did it every weekend, that one vial would be great.
And was it you were you aiming for the K-hole, or were you aiming just to exist?
No, just to feel good. Definitely
interesting.
Not pursuing the K-hole at all.
Interesting.
So you guys know something about ketamine there. The K-hole was
I do this for a living.
All right,
like my job. Like obviously, there's a lot I don't know, right? Like you'll see, but because with ketamine, I also didn't know how to get people off of ketamine, right? Especially if it's a part of the culture, right? And then they sometimes have urinary side effects and stuff too.
But why I bring this up is just specifically on, can you kind of explain that tolerance level, and perhaps more because of the case we're talking about is opiates. So can you tell me why, I would need a certain level of opiates today, and why I will need more tomorrow and the next day and the next day, even in the context of if I have chronic pain and I'm for whatever reason.
There's ventral tegmental area and there's the nucleus accumbens. These are two areas in the brain. And that's really where we're
going to spell those out for people.
Sure. I mean, that's where the reward comes from,
right?
It's from the dopamine that comes from there. And it's a bit sort of controversial, the scientists are getting better and better at it. But, is it the firing of the neurons? Is it the dopamine released to the area in between? Is it how the dopamine is released and fired? And on the other side, where the nucleus accumbens, they have these receptors. That respond to that heightened dopamine in the brain, and if you keep flooding it, they're going to stop. Like some of them have like time things where for a certain period of time they sort of cut out for a bit. Sometimes they have downstream messengers where things happen where it's just basically what ends up happening is that it's like you flood the system. But then anything that you flood the system with, right? Like, say, even if you're sitting in a room and there's like a loud noise in the background all the time, eventually you stop noticing the noise, right? And the same thing happens for these cells in the brain that are there for reward. Eventually you sort of stop noticing it. It's complicated for opiates because opiates don't they're like this indirect thing for the release. They also work on this the amygdala. They also work on this PAG area, and what those areas do, they do anxiety and pain and fear, right? And so part of the opiates is you get this reward, right? But it's a secondary further away, and then with the fear, it makes that go away as well, right? The fear, the pain, that kind of stuff. But basically, I think a simple way to look at it, it's almost like if you've got like something like you've got clothes on your skin, right? When you put the shirt on, you feel the shirt.
Yes.
After a while, you don't feel the shirt. You need a bit more pressure, right? And the brain sort of adjusts to what's there for that. And then also it happens in other areas as well, right? So with things like opiates, they affect your respiration rate, right? So they affect different areas of the body and the brain, and all the receptors are slightly different in how they adapt and adjust.
Okay, here's a question that kind of is related to that. So I always wondered, I think the maximum dose of a patient I've ever supported on methadone was 240.
Yeah.
And I didn't go deeply into that. I don't know I actually do know. I do know that he didn't start at like 20 and go up, but it was a very high start, and that's kind of where he navigated to. But he was there for 10 years.
Yeah.
Why is that same thing not happen? Why are people that are starting on 100 of methadone not at 800 in 10 years? If it's a tolerance issue.
With these oxys that people use and those other opiates, a lot of times they'll use the short-acting ones, right? And so they'll crush it, snort it, sniff it, right? And so what happens? They get the high, they get the withdrawal, they get the high, they get the withdrawal. And in the beginning, so there's two things. This part I can describe better, right? So there's an A process and a B process, and my cartoons are horrible. I don't know if I should draw it or if I should just draw it later. But basically, the first time you use cocaine, the A process, the high is pretty fucking good, right?
Yeah.
Like it's pretty good. Sort of like your ketamine experience.
Yes.
And then the problem is the more you use, the A process gets smaller and smaller and smaller, but then this other thing happens. It's like this B process. It's this B process of like withdrawal, negative thinking, all that kind of stuff. And the more that you use substances, the same substance, the reward gets smaller and smaller, and the withdrawal gets worse and worse. And so with methadone, because it has a long, long half-life, you don't get that same withdrawal anymore, right? So people who use opiates, initially it's for the high. After a while, it's just to stop the withdrawal.
Okay.
Right? And then to stop the withdrawal, they also still want to get the high, so they got to cover the withdrawal, then they got to get the high on top of of it, right? And so methadone takes away the withdrawal, but people still use on top of it, right? Because they want the high. So methadone is very good for the withdrawal. It doesn't always replace that high.
Okay.
And so you get certain people where they just can't stop, and so they'll use fentanyl right before they get their methadone dose. They'll use it right afterwards. They're passing out in the waiting area.
Yes.
All that kind of stuff, right? And so whereas buprenorphine's a little bit different, right? Because it has more of a blocking effect. But with methadone, you can probably that's why you get people on 200 of methadone, 1500 of Cadian, which is a slow release oral morphine, and the dose just go up and up. The other reason we don't go up on methadone is the heart, right? And so there's a thing called the QTC interval. And when you look at the data, it's not fully clear how much it actually increases the risk of having an arrhythmia, but the higher the QTC interval, and some psych medications cause this as well, you have the risk of just developing this arrhythmia and your heart stopping.
Right.
And so you have to weigh that risk as well.
Right. But ironically, it's not, I understand why you would want to keep it at a certain level, but that doesn't seem to be the number one ask of our methadone folks, right? They're not really pushing. If they're stable on methadone, I don't really hear that. Maybe, obviously, you have more encounters of that than I would.
Yeah, because their withdrawal's good. Right,
so they're not saying, if they're at 110 and they've been there for 6 years, they're not coming to you every week. Can you do 115? Can you, like, it's not like they would be if they were on, Dilaudid or something, right?
Dilaudid, they'd keep wanting to go up, and historically, when the pain docs were pushing it to cover pain, they would say there's no maximum dose for it, right? And I suspect, I might be wrong, I suspect it has to do with the waves. Yeah. Right, because even if you're on like hydromorph content or oxycodone, usually you have to do twice a day or 3 times a day dosing, right? And so when you talk to people who work in hospital, like those pain service people we work with, they always do 3 times a day dosing. You talk to chronic pain physicians like physiatrists, they'll do the twice a day dosing for it. And so it's really hard with 2 times or 3 times a day to get that right level, because it's always going to come down. Whereas the methadone, it just sort of goes up and it just lingers.
Right. So back to our case at hand here. So if, again, this is all, well, it's not allegedly about the substance use. This is both what the prosecution and the defense are saying, that he has this opiate use. So he's acknowledged it and he's open about it now, after he's been charged with murder. But it's, he's going up. If you could get to that $50,000 a week, it's because he's chasing that A, right? He's often a phrase uses chasing the dragon.
Or he's trying to stop the withdrawal. Right. It's both, right? So during the day when he has to work, he's probably just trying to stop the withdrawal, and then the evening he's trying to, and this is why buprenorphine is so good, right? And we don't always talk about this. We could get rid of that withdrawal for him. He could like, instead of buying all those oxys, he could buy all those oxys and buy some buprenorphine, have a coach on how to get on it properly, because now we have creative ways, right? Historically, you had to stop the opiates for about 24 to 48 hours, depending on which drug you were using, and you had to go through the withdrawal before you could start on it. You don't have to do that anymore. And so if he was seeing me...
Not that we're offering Alex Murdaugh medical advice here, but a patient with a similar profile...
Yeah, so if I was seeing somebody who's using that much oxycodone, I would have a session where I just get them to talk, what they care about, what's important to them, what the challenges are. I get them to talk a lot about the negatives,
yes,
right? I mean, a little bit about what it does for them, but more about the negatives. And I try to make them link the negatives to the fact that the negatives of the substance use create the state that makes the person want to use in the first place. Right. So you try to sort of get that buy-in, and usually I can start with the withdrawal. And usually I can start with the cost, and then we could find a way so that he doesn't have withdrawal, and then he just gets a little bit of the high first, because at least he's not going to die with the buprenorphine on board.
So, I mean, not that we're here to pass judgment, but it's certainly from a sniff test of people that work in addiction, it kind of, to us, sort of, would you say it passes the sniff test? This is possible that someone could spend $50,000 a week?
I think so. I think somebody could spend that much a week.
Yeah.
I would hope they would have some business partners that would help them find another way to
function and I think,
right?
Unfortunately, this has been one of the challenges. So and I know I just sprung this case on you. It wasn't something you're familiar with, but just to give you a little bit of the background is the allegation is that he had already stolen somewhere in excess of $10 million from his law firm to pay for the oxycodone.
Yeah.
And because it's been going on for 2 decades. That's his disclosure. That's their allegation. So I don't think we have to say allegedly before that.
Yeah.
So he'd already been behind this, and the allegation is that this murder was done because he was about to be exposed for that theft, and he's facing also 99 financial charges in addition. 99 felony financial charges for the theft, from stealing from the trust funds and all these situations. So he was in deep. I think everyone can agree that he was in deep at that point before the alleged crime took place.
When you said 50,000 per week without mentioning the drug, I was assuming like, stimulants, psychosis, things like that. But it'll be interesting to see what plays out. Although I'm probably not gonna. I find these. It's upsetting, it's really upsetting when you hear about these things. My point is that there's certain people that prefer the oxys because it's a pill. Right, it's a pill. It's made by a company. They know what's there. They know what the dosing is. They know the amount, and they're not going to want to switch over to something that's unpredictable. Right,
right.
Like some kind of goop or gunk or whatever fentanyl looks like.
Yeah, what fentanyl looks like at that time. And again, he's trying to keep control of things, I would imagine, obviously, because it's in the shadows, as we've said before, and so he probably wants just the brand name product. So you got to pay more to get it, and there's a huge problem with people. There's a huge opiate crisis around the world, but in particular, apparently in South Carolina. So this is where this gentleman practiced.
The other thing is, in a lot of these places, I've looked at South Carolina, they have a lot of very rigid policies on even getting access to methadone or buprenorphine. So here we regularly use it as a harm reduction tool, which is what methadone originally was considered. And you can show up, we'll give you some tablets, all that stuff. There, I don't know what their rules are, right? You have to be a certain kind of prescriber. Maybe you have to document that you've given it to this person.
It's not as low barrier access.
Yeah, not as low barrier access, and I mean, and to be honest, I know people that have had mental illnesses that are scared to get treatment because of it getting in the system and stuff like that.
Sure.
So I can't imagine what a lawyer is like after having tried so many cases, seen so many judge things, to even have one medical report that he has an addiction, right?
Exactly.
I can't imagine what that would be like.
I mean, the story why it kind of caught my eye is that I don't like the fact that this addiction was tied into this criminality, in the sense of, I'm not saying there was criminality, but if that seems to be the allegation, well, I was a drug addict per se, so that's why I did it, right? That seems to be what.
Oh, you don't like the drug use as an excuse for a crime?
Yeah. I don't like the connection of the two, that the prosecution
it's not good for our patients, right? Like they're not all criminals.
Exactly.
And the same thing happens with like bipolar disorder and schizophrenia.
Yeah.
The rap that they get it's horrible, right? Like just because you have schizophrenia or bipolar doesn't mean you're going to kill somebody or steal something.
Yeah.
There's so many people that have those diagnoses.
Exactly. Yeah.
But the way that it's presented in the media, I get very upset by that.
Yeah. So that's how it. That's how it keyed into me first. Drug, just because he has. I get it. He could also have a drug addiction and be a murderer, but it doesn't mean that the drug addiction is connected to this murder.
I mean, and that's why I think I immediately went to the stimulants, psychosis, because I was like, why are they making such a big deal out of the drug addiction?
Yeah.
But I'm not familiar with, being high on opiates resulting in you planning to murder and kill someone, right? I don't think that I've seen, like, with stimulants where people's brains are vulnerable, where they get paranoid and suspicious. They come with this whole story that they believe is real, right? And I've seen that in the news and otherwise, but I've not seen somebody who uses opiates who murders somebody,
right,
and it being because of the opiates, if that makes sense, right? Like I've not seen that,
right?
But I've only been working 10 years. I don't see, or 12 or 15 years.
But it doesn't mean there's a correlation between the substance use. Drugs don't make people steal, and they don't make them kill their families.
Yeah.
I mean, they're notwithstanding psychosis.
Steal sometimes people steal because they need to maintain the addiction, right? That I can.
It happens.
Like, whether it's going to the dollar store and taking some rubbing alcohol, or whether it's like the person that you said had no means, but they got the $20 tablet of buprenorphine.
Yes.
And I don't ask about those things. I don't know if I should be.
Right.
I don't ask. I'm just happy that they're there, and then I just try to reduce the risk and the harm. Right.
But there are people, such as myself. I made it through the journey, and fortunately was able to keep myself financially together the whole process, and I've never taken anything from anybody. And I think there's a lot of people like that, especially a gentleman that has the means that this gentleman had, or has, right? He still has millions of dollars of real estate. He still, he had, millions of dollars in the bank. I mean, he probably could have kept it together without stealing money. And I get it. There's a connection in some ways there of the desperation as to what people will do.
But it's not an absolute, right? And
Right.
correlation doesn't mean causation, and I don't even know if it's correlated. Like it might be. I don't know. Like and I think it's wrong to imply that, because it does harm to a lot of people that almost they had like very little choice, right?
Yeah.
Because once the addiction grips you, or the opiate use grips you, even if you care about other things at first, you stop caring about them, more and more that you get deeper into it,
Yeah.
And I always want to be mindful, because some people choose to use and all that stuff, and that's their choice too. Maybe I could just summarize the take homes, because I think we're like a little bit, we went through a few different ideas. I didn't know where we were going with this. I do know now, and I'm really glad you brought this case up. Right, so I think there was a story in the news that interested you, right? And you're like, hey, let's chat about it. And you thought that, hey, 50,000 a week, is this realistic?
Yeah.
Right, and and then you thought about what would be preventing this person from getting treatment, because the harms of spending $50K a year over 10 years, or whatever, 10 million that he stole, and this whatever happened now, is much worse than getting treatment would be on anyone's life, right?
Sure.
Well, maybe not.
But at the time, who knows?
At the time, who knows? Yeah. And the stigma piece, and then also around the tolerance piece, right? And I think the A process, B process is something that would be a lot of fun to talk about, because there's a very clear biological basis. There's a lot of animal models, for it, that talk about it, and it also explains why certain drugs work for certain things, right? And so methadone is very, very good for the withdrawal. Doesn't help everyone with the cravings and so forth. So
okay, all right, and that's our take on the Alex Murdaugh case, and may Paul and Maggie Murdaugh rest in peace.
Oh God, yeah.
Okay, thank you.
You.